Welcome to week 2. This week we will focus on healthcare systems in Canada and other selected countries. So part 1 will discuss how healthcare is divided up in communities and in countries and in different healthcare systems and why that happens. And then we'll focus in on the healthcare system in Canada. So healthcare systems, distributive justice. The ethical principle of justice means that everyone receives fair, equitable, and appropriate treatment in light of what is due or owed to them. But there is typically a scarcity of resources in healthcare and a lot of competition for the resources. So it is impossible for all people to have everything they want or need. Distributive justice, therefore, is used by governments to try to ensure a fair distribution of goods and services. We need to keep in mind, though, that if a society puts more money into healthcare, then other aspects of that society will likely suffer, for example, education and social services. It can be very tricky for governments to figure out how to share the resources. There are many difficult questions that governments need to ask. For example, who is entitled to receive services? Do people have a right to health care? How much healthcare services should be provided and to whom? What does a society mean by fair distribution? Governments generally use a combination of systematic ways to decide how resources should be distributed. So material rules, such as to each person, an equal share, maybe according to need, etc. Which material rules a government views as important is often reflective of the ruling party, of what the ruling party considers important. So in Canada, some health care is provided by the federal government, for example, armed forces personnel, Indigenous population on reserves, but most healthcare services are provided by the provincial territorial governments. The bottom line is that societies need to thoughtfully and systematically set priorities based on ethical positions if they want to find workable solutions to the current problems in healthcare. So, how do decisions get made about how to spend the limited resources that are available? Well, theories of distributed justice arise from common morals and ethics. Given the many differing views about justice in any society, it is virtually impossible for a single theory to meet the needs of everyone. But there are 4 common sets of distributive justice theories that may help you understand competing social goals. Egalitarian theories. So people who are similar should be treated similarly. The goal is equal distribution of social benefits and burdens, and there is recognition of a social obligation to eliminate or reduce barriers that prevent fair equality of opportunity. However, it does not mean that everything must be shared equally, but there should be a minimum that everyone should receive, and we see this in Canada to some extent. Utilitarian theories. So utilitarianism is based on the rule that it is good to maximize the greatest good for the greatest number. So these theories could favor social programs that protect public health and distribute health care fairly to all citizens, because such programs should maximize utility. However, these theories place aggregate social good before individual rights, and so they usually end up limiting the services that are available to the sickest and most vulnerable in society. Libertarian theories, they focus on how a just society protects the rights of property and liberty of each person. So they are very much about the individual rather than the community or society. They classify healthcare not as a right, but as a commodity that operates on the ability to pay either directly or through insurance. These theories are entrepreneurial and are characterized by people or companies taking financial risks in the hopes that they make a profit. So if you can afford to pay for it, then you can get the best health care. This is the USA. Lastly, communitarian theories are all about the community rather than the individual. The value of public good is important, and values are rooted in communal practices. So human life will be better if collective and public values guide people's lives. These theories include commitments to equal access to healthcare, and we see this in Canada to some extent. So what do these theories about distributive justice lead to for healthcare in Canada? Well, it's important to understand that despite what many people think, healthcare is not enshrined in the Canadian Charter of Rights and Freedom. Even the Canada Health Act only notes the importance of accessible healthcare rather than conferring a right to healthcare. In fact, the 2004, the Supreme Court of Canada ruled that the Canada Health Act and associated provincial and territorial legislation do not mean that all medically required treatments will be funded for any Canadian. Yet Canadians try to use history to justify their expectations and to distinguish Canadian healthcare from the American system. And they like to claim that Canada is very different from America. There certainly are differences, though these differences only became evident later in the 20th century, as up until then the Canadian and American systems were really quite similar, especially when Quebec is not included in the comparison. Both English Canada and America were originally British colonies, so it's not surprising that they were similar for many years. Both are federal systems, and healthcare is split between federal and local levels of government. So provinces, Ontarios in Canada, and the states in the US. The differences between Canada and the US started to appear more broadly from the mid-1960s, early 70s as Canada introduced national insurance. But at first, the US kept on a similar track. For example, with the establishment of Medicare and Medicaid in 1965. Prior to 1957, most healthcare in Canada was privately funded and delivered through the Hospital and Diagnostic Services Act. Saskatchewan, in particular, Premier Tommy Douglas, led the move towards public healthcare that institutionalized the power of physicians within medical services that are administered publicly and financed through taxes. So generally, physicians bill the government for services rather than get paid a salary. And this was after, in 1962, Saskatchewan's physician strike. In 1966, Canadian Medicare became a reality through the Medical Care Act. From about 1957 until 1977, the federal government paid 50% of costs for provincial insured hospital and physician services. This arrangement changed to block funding in 1977 and eventually changed to the Canada Health and Social Transfer and later became the Canada Health Transfer. And that began in 96 and 97. And that's the Canada Health Transfer is the amount of money that the federal government will transfer to each province territory. So in 2020-2021, the federal government planned to transfer $81.6 billion to the provinces and territories. But for Ontario, $22 billion was given to Ontario, even though the 2019 total budget for healthcare alone in Ontario was $65 billion. So just let's recap this. Ontario was given $22 billion from the federal government to provide healthcare, but the budget that Ontario needs is $65.3 billion. And so the province has to come up with the balance. And so this is almost a 40% of the total Ontario budget of $163 billion. And so in order to run Ontario, the budget to run Ontario for everything, social services, education, healthcare, is $163 billion. But our healthcare budget alone is $65.3 billion, and we're only getting 22 billion from the federal government. And so that amount was about 5 billion short of what was needed to just maintain services. And that's pre-pandemic, of course. And then what was decided in the election series last year was looking at a national pharmacare plan. And I'm going to discuss that a little bit more at the end of this lecture. So let's look at the Canada Health Act. So since 1984, when the Canada Health Act came into being, there have been various shifts within healthcare in Canada, especially with some changes within the provinces that continue to limit services. The implementation of the Canada Health Act was when the insured plans in Canada and the US really started to diverge. Virtually all Canadians now have access to healthcare services, whereas millions of Americans under 65 have no health insurance. However, the Canadian system is overloaded and can't continue without some serious changes, especially as technology increases, the public want more services, and healthcare provider costs continue to escalate. Something has to give. There are 5 principles in the Canada Health Act that provide the broad framework for how healthcare should be offered across the provinces. And they are universality, accessibility, comprehensiveness, portability, and public administration. Though there is not a lot of wiggle room, there is some. For example, delisting of eye exams in Ontario was allowed because the province made a case that they were not medically necessary services. As long as provinces continue to provide services within the requirements of the Canada Health Act, then the federal government will keep paying some costs. So there have been calls in Canada for a long time about the need for universal coverage for prescription drugs. The federal government finally brought together a task force that made its final report in 2019. Some of the key points in this report were that Canadians spend $34 billion on prescription medications in 2018, and drugs are the second biggest expenditure in healthcare after hospitals and then physicians. On a per capita basis, we pay more for prescription drugs compared with other countries except for the US and Switzerland. Yet 1 in 5 Canadians struggle to pay for their prescription medications. Many don't fill their prescriptions because they can't afford to, and they cut back on other essentials such as food and heat, or take out loans and mortgage their homes to be able to afford their medicine. Canada is the only country in the world with universal health care that does not provide universal coverage for prescription drugs. The authors of the report identified 5 fundamental principles for a national pharmacare plan that fits with the 5 principles of the Canada Health Act. So first of all, universal. All residents of Canada should have equal access to a national pharmacare system. Comprehensive. Pharmacare should provide a broad range of safe, effective, evidence-based treatments. Accessible. Access to prescription drugs should be based on medical need, not ability to pay. Portable. Pharmacare benefits should be portable across provinces and territories when people travel or move. And public. A national pharmacare system should be both publicly funded and administered. The plan to roll out national pharmacare started with funding that was announced in the 2019 federal budget to create a Canadian Drug Agency. Amongst other responsibilities, this agency was to create a national formulary and have an initial list of drugs available for January 1st, 2022. Over the next 5 years, using $500 million per year that has already been committed by the federal government, additional drugs were to be added, and a strategy for funding and giving access to expensive drugs for rare diseases was to be in place. The full national formulary was to be in place no later than January 1st, 2027, with provinces and territories delivering national pharmacare by 2023. Given the economic cost of COVID-19, it is not clear if and when this plan will unfold. Stay tuned for the next mini lecture on healthcare in Ontario.